Apelqvist.
Well, in this end of the day, we're going to talk about this sexy topic. If I was going to start to be a doctor 40 years ago and now say 40 years later you're going to lecture economics, I don't know if I would believe them. But what I'm going to try to give you a little bit of a picture, because as a physician or doctor, we always look at economics as an enemy. But you have to realize that, for example, in Scandinavia, the main reason why we actually got diabetic foot team and a strategy to prevent amputation, that was the economic burden of the diabetic foot. And therefore, we have to also realize that it actually is a very valuable tool if you start to understand it. So what I'm going to try to give you a little bit of a hint is how to look at these kind of evaluations, because like any kind of method, you can also do a lot of cheating by health economics. And there are actually experts who do trials in this area. You can actually prove anything you like. The first problem we actually have, and a lot of the previous speakers has been talking about it, and that is actually regarding reimbursement. But you see, from my point of view, reimbursement is not parallel with cost. So my point of view, the first statement I would say is that you should look at the resource utilization. That means basically, what kind of efforts do you put in to achieve a specific goal with regard to the treatment of your patients? And in the end of the day, those resources is transferred into monetary terms. That's basically what health economics is about. The first is regarding the global cost. People are not unaware of that. Actually, probably regarding health economics, the diabetic foot is with regard to diabetes the most resource-consuming problem with regard to diabetes. In India today, 40% of the cost for diabetes actually is related to the foot. These are some of the summaries from Europe regarding the resources and regard to the communication we have with the European Commission for the moment. So for the moment it's estimated, remember now it's an estimated, that about 10 million euro is regarding to, in the European Commission with regard to the diabetic foot, and this is only the direct cost in that sense. The cost from US, this is what we find from your reimbursement data, that approximately 1/3 of the resources spent in US regarding diabetes could be related to the diabetic foot. And now, if you then go to the literature and try to go through these papers published about costs, in this case, the table is regarding papers that look at costs for healing without an amputation, you will probably get very confused. Because you can see it's a mix of figures. The range is enormous, from about 2,000 euros up to about 5,000, 15,000 euros. And the problem actually, what you can see is, rather quickly, is how they have collected their data. They are actually totally not comparable. If you then go and look at the cost for amputation, you see a tremendous difference in cost. So the key message from these papers basically is just that actually almost in any study you can see today, the cost for amputation for an individual who has had walking capacity before developing his lesion and has his own living is about 6 to 7 times higher compared to if you heal that individual without a major amputation. That is consistent country by country by country if you find that. But the problem is actually how come to this data. There are very few prospective studies. This is what I call almost a study prepared for the museums. It was a study on 314 patients that we followed prospectively to healing. We looked all resources spent, and we've all of also followed them 3 years afterwards regarding resources spent. And you then see the difference regarding healing without amputation, the healing by amputation. The interesting point is also the proportions between in and out patient cost. And remember now that that depends truly on what facilities you have outpatient. The key factor is in all health economic studies, basically, you have to follow the patient to a specific outcome. Otherwise, it doesn't reflect the total resources spent in a specific situation. So the result from that study was, now this is in Swedish terms from 1998, you can see the same thing, that there was a difference regarding primary healing and healing with minor amputation. That study changed the healthcare system in Sweden. But the interesting point regarding cost for major amputation is that 77% of all costs for major amputations incur after the amputation. So remember now, amputation as a technique is very cheap, and it's a very good way to get rid of the patient, because you can get rid of him from your clinic. Somebody else take the consequence. And in Sweden, it's the primary care unit, the nursing homes, and the home care. There the cost will come. Because also you will see, if the patient survived the major amputation, you will see in this case, another 500,000 Swedish crown will be spent on that patient because of increased need for home care social service. And these costs are usually not included in evaluations. And the interesting point that these were pages, as you say, from 1995. We have data for 2005 now, and the interesting point is that the proportions is still the same. So even if the figures are different, the proportion is the same. And this is from the Eurodive study, who did the same kind of evaluation in a substantial number of European countries. You always see the same pattern. But you also see now that the complexity of the wounds, the severity of the wounds immediately, as expected, increases the resources that you have to be putting in to treat that kind of patients. That is what you can see, and that is the value when you want to describe in your catchment area why you have to do something, and why you in principle should avoid a major amputation is a patient who has a walking capacity. But then when you go into the specific cost, then you come into a problem, because actually what it is mainly an iceberg, because you will find a lot of these kind of figures, because many times this analysis are not including all resources spent per specific problem. If you talk about dressings, people look at the cost for dressing, but I will warn you, the cost for a dressing in primary healing might be about 20% of the total cost to treat the patient. So you have to be very careful what data are actually included in the evaluation. The first thing to understand is that we are talking about direct cost, indirect cost, intangible cost, and outcome. You always have to relate your resources spent to a specific outcome. And the key factor, we can do it very, very easy for you. These are the basic concepts you have to do. You shouldn't look at the price for what you're doing in the beginning. You should just collect what resources do I spend. And these are the items that you have is the minimum requirements for looking at the analysis of any kind of intervention today. And that means basically that if you don't have included these kind of data, you actually have a severe selection bias in your evaluation. And I can leave it more complex because how detailed you can be in this area. Various of these items might be more or less important, but they are also influencing your analysis. And the problem in these case of patients is actually to divide which resources are related to the diabetic foot and which are related to concurrent disease. And then we go back to some of these studies to now try to analyze them. Then you see suddenly, if you look at cost determination, that the majority of the studies presented actually isn't the actual resource spending. It's actually what has been claimed. That is what you have been paid. But that is actually not the resources spent. So only 3 of these studies actually have to follow the protocol to analyze what resources were spent. So some of the studies what you see, I'm not going to give them to you in detail. One of the earliest studies was a paper by Ulcer, and the important with that was actually that you could actually see that you can relate the cost into this grade of severity of the ulcer. The more severe, the more resources spent. So the message would be the earlier you start your treatment, the less expenditure you would have. Ramsey in 1999 did another study and also focused very much on inpatient care that you also have seen that previous speakers have been talking about. And then you had another study from Harrington in 2000, and the interesting point, and this is a Medicare study, but the interesting point, that was one of the first studies actually to look at where the cost incurred. And you see here, as in almost all of the US studies, above 70 to 80% of the costs are related to inpatient management. Whether that is correct or not, we actually don't know, because we don't know how much of resources and cost are related and transferred to the patient and his family. It doesn't relate to the actual resources being spent. And then you have Stockwell paper, it's the same paper, looking at the same thing, clearly related to the severity of the ulcer, where there is how much resources you have to be spending. But now, when you look at these things and you want to compare center by center or study by study, you have to collect, as I told you, these kind of data. And this is from the Eurodial study, that these data are the data you have to collect. Because if you don't have that information, you will do a very severe selection. The interesting point in the Eurodial study was that the total and direct and indirect cost was about 10,000 euro per patient. In this case, independent of whether they healed or not. And you see the indirect cost were only 645 euro. And the reason for that was in this Western European study, most of the patients already, when they have their kind of lesions, were disabled. They were outside working. And that means that this study is only relevant for European situation. So how that situation and the proportion of indirect cost regarding production loss, etc., is related to each country, because it's totally different country by country. And you can be very cynical also if the indirect costs are high, because if you have an unemployment rate of 11 to 12%, it doesn't matter if you lose production for the society, because it's always somebody else who will take that job. This is the same graph, and you could see also that in that study, still in-hospital stay took about 35 to 40% of the resources with regard to treatment of these patients. Now, if I go back to all these studies and try to summarize them for you, what are the cost-driving factors? What incurs the highest resources? Well, I've told you that major amputation results in higher resource utilization versus primary healing, and that it basically is the consequences after amputation. But the other most important factor is actually wound healing time, the number of surgical procedures, in-hospital stay, the severity of the wounds, and comorbidity. These are the 6 most important factors related to high resource utilization. So basically that means that in-hospital stay alone is not the major denominator. The key factor is also the people believe today that they save money by putting patients out of hospital. But remember now, if that doesn't result that the patients actually have healed, it's only that you transfer the cost from one budget to another. And that is the dangerous thing, that we have what I call the transferal game, that we transfer patient from unit to unit. Another way of looking at it is also to compare cost between countries. This is a data from 2003, comparing costs between United Kingdom and USA. As you can see, you should probably transfer all Americans to UK, and then you do your amputation in UK, and then you will probably save money. Of course, that's not the truth, because the key factor is actually what data they have included. So in the UK data, cost for rehabilitation was not included. As a consequence, the data is not comparable. And this you can't read, and that is intentional, because this is from the Eurodial study, where we compared the same patients that were treated, as you can see, in actually 7 different countries. The average total cost per patient was between 1,200 and 27,000 euro between the countries. And here you could actually say that you could export every patient to Slovenia because they were cheapest, and you should never treat the patient in Denmark because they are expensive. How come? The difference is number of surgical procedures and the salaries of staff. So in Slovenia, they have very low wages. So you have to understand, don't go into cost. Look at the resources you spend in hospital stay, number of days, number of surgical procedures, how much of antibiotic do you use? And then you put it together, because otherwise you can't compare data. Because this is another study that looks at these things. It's a 3-center study regarding diabetic foot patients prepared for a clinical trial. And you can see that there's a difference between hospitalization rate, hospital stay, use of IV antibiotics, surgical treatment, angioplasty. The key question for you will be, okay, what's the best center? Which center would you want to be treated in? But the interesting point that one major reason for the difference was actually reimbursement. So the center who has the longest in-hospital stay, they had a higher reimbursement for putting patient into hospital, and they will not allow to follow the patient on an outpatient basis. The center with the lowest in-hospitalization rate had a concentrated system with a close cooperation with primary care, GPs, and nurses on outpatient facilities. So you see now how dangerous it is just compare straight over in this situation. So basically, we can see the differences in countries are basically related to availability of specific techniques, preference for treatments, and also economic factors, actually how you price things. The key factor is actually very important. Mostly, in most cases, the patient's characteristics is the same. So the key factor for you when you come into treatment, and why my colleagues now talk to you about interdisciplinary care, is basically this old story that I showed you earlier this week, that you have a patient with a foot ulcer. Day 3, somebody starts to change dressing. Day 8, somebody introduced antibiotics. Day 23, painkillers are introduced. Day 34, the patient goes on elective gallbladder surgery to the surgical department, stays there for a week, no report at all in the records of a wound. Day 43, the patient comes home, another GP introduces change of antibiotics, painkillers, and an ankle-brachial index. On day 52, the patient comes to the hospital's Department of Infectious Disease with a foot infection. Puts into hospital, they do revision, IV antibiotics, put the patient out of hospital with a referral to the Department of Vascular Surgery, who happens to have a waiting time of about 2 months. And on day 73, the patient comes as an emergency to the Department of Orthopedic Surgery with a 4-foot gangrene. On day 74, you do an emergency angiography, and day 75, 2 vascular surgeons do a heroic distal bypass to the pedal arch. And on day 86, we do an amputation. This is what we call a flow chart. The interesting point that this is the pattern we see for many countries, but what I want to use this for you is this is the same history. The patient, the cost for that treatment, uncontrolled transferal, cost the healthcare system 43,000 euro. Would you call that efficient? That's the reason why interdisciplinary had to be coordinated, because if you treat the patient in that sense with the same problem, the cost immediately will be reduced at least 50%. And that's the rationale why actually multidisciplinary treatment, interdisciplinary coordination is cost effective if you look at the outcome of the patient. If you only look at what the resources spent immediately the first 72 hours in a team like that, then you would always say, as a hospital director, you should almost remove the teams because you can only get reimbursement by one. So that's the reason why you have to coordinate your efforts in that sense. So what we know from what we call Markov or modeling analysis, basically it means that if you, with your treatment, achieve either a 25 to 40% reduction of development of ulcer or amputation, you are actually cost effective. You are not cost effective if you start to do prevention in healthy diabetics without neuropathy, but you are very cost effective if you start to use patients with one risk factor, neuropathy or vascular disease. Then you are cost effective. The interesting point is you are most cost effective in the elderly population because they incur the most resources spent in the healthcare system today. The warning regarding Markov modeling is that these models are no better than the raw data you put into it. And you have to be very careful when you read these kind of modeling, because they are always have that limitation, what kind of reality data has been put into them. But I think it's also one thing that is major essential here, and that is we now have talked about resources with regard to the healthcare system. This is a paper from Peter Kavanagh, which I think is very, very important, because it actually talks about the consequences for the patients regarding how much of their monthly income would they lose, have a consequences country by country if they have an ulcer with primary healing or with an ulcer that ends up in the transtibial amputation. And you can see then that the patient for an amputation in India, for example, he will lose probably about 68.6 months of payment. So the financial consequences for the patients is enormous. And these kind of information you will never see in claims data. You will never see them in any kind of cost analysis because we don't do them from the patient's perspective. So the consequences from the patient perspective is enormous, and especially in countries from what you and I call privileged, we call them the developing countries, even if some of them now are getting more richer than we are. So what is the problems? What can I send you as a message? Well, the first mention is, what is the problem that this healthcare analysis shows you? Yes, that is a total lack of communication and coordination between various disciplines. That is what the diabetic foot shows you. The basic healthcare system that we have is actually old. It was created many decades ago. It's not adapted to a multi-organ disease patient. And usually also have that most health economic analysis is not from the patient's perspective or for the outcome of the patient. It looks frequently at the cost for the hospital, and the hospital can gain money by transferring the patient to somebody else, or you can gain money by transferring the patient to another clinic. So basically, you have to see what is the wrong with your healthcare organization to make it more effective to treat these patients. The other problem we have in the system today is that everyone talks about budget restrictions, but you see cutting expenses might be just that we transfer the cost to somebody else. For example, I could actually transfer patients to Andrew Bolton, and then probably my clinic would make me a hero. So the other thing you have to be very wary about is the difference because cost and charges. We talked about hyperbaric oxygen, why we couldn't measure cost, because the key factor is that what you are charged are not necessarily the actual cost. And also be aware of reimbursement, because reimbursement is a very, very strong incentive to actually guide your acting. You have to reconsider how much of your acting today is related to your reimbursement system to actually gain as much income for your hospital or clinic as much as possible, and how much of it is related to what you actually believe that the patient is needing. So, and basically when you look at these kind of health economic analysis, you should always include costs until final outcome, either healing with amputation, or death, basically. And remember from health economic, death is a very, very productive way to solve a problem. The cost stops. So health economic analysis also has a short lifespan. You see that most of these studies you show were rather old, and that's dangerous because immediately you change anything in the flow with the patient from clinic to clinic, GPs to nurses, etc., you change the pattern. And that means, for example, when you introduce endovascular techniques, that probably have a severe consequence regarding cost, comparative reconstructive vascular surgery. So don't underestimate the reimbursement. In my point of view, reimbursement today is probably the most dangerous adversary to diabetic foot, because as long as you don't have a reimbursement for prevention, but you actually can get a higher reimbursement for chopping a leg compared to preventing a foot ulcer, then you have very large difficulty to be successful. Thank you.